So the next speaker is Dr. Megha Gulati. Dr. Megha, she is speaking on a curious case of recalcitrant focal endogenous endophthalmitis.
Good evening all. So here I will be dealing a case of endogenous endophthalmitis that was recalcitrant. So a case of endogenous endophthalmitis that was recalcitrant to our conventional management therapy. So 59-year-old male hailing from West Godavari, Andhra Pradesh presented to us with left eye diminution of vision since 2 weeks. Now right eye ocular examination was unremarkable apart from grade 2 nuclear sclerosis. Left eye he had a visual acuity of 2250. There was grade 2 nuclear sclerosis. In anterior chamber there was inflammatory reaction of cells 3+ along with the cells in the anterior vitreous phase. Now fundus examination showed grade 2 vitritis. We can see disc and the retina very hazily, and in the nasal quadrant you can see this small whitish pearl like thing, that is string of pearls as marked by the dots. Now the periphery examination of same patient showed a 1.5 disc diameter yellowish fluffy necrotizing retinitis lesion. It's having ill-defined margins. It's there in the superior nasal quadrant. And the main characteristic of this lesion was it was growing and extending into the vitreous. So when we saw clinically, we could appreciate that it is coming into the vitreous cavity and not just confined to the retina. The same was confirmed by the OCT line scan. Here you can see that the hyperreflective lesion is protruding from the retina into the vitreous. Now on asking positive history, he had a gastric outlet obstruction recently, for which he underwent a distal gastrectomy, jejunostomy and jejunojejunectomy 2 weeks prior to when he presented to us. And for this he underwent a gastrointestinal surgery. The mass was excised and was diagnosed to be a poorly differentiated adenocarcinoma of stomach. Now during his admission, he didn't had any signs of sepsis. There was no fever. Now we were dealing with a case of vitritis with retinitis with a history of 2 weeks prior gastrointestinal surgery, for which central line was also secured. So likely we were dealing with a case of left eye endogenous endophthalmitis. Now whenever we see a case of endophthalmitis endogenous in origin, we have to ask 3 questions, whether it is focal or diffuse. So in our case there was no doubt because we could see a focal retinitis lesion. So it's a focal endogenous endophthalmitis. Now what is the likely etiological cause of this endogenous endophthalmitis? Now there are many clues on clinical examination itself which give us the answer. It had a string of pearls appearance. There was a focal retinitis which were growing into the vitreous, so a rain cloud sign on OCT could be seen, and there is a history of prior gastrointestinal surgery. So likely the cause is fungal, that is Candida endogenous endophthalmitis. Now we have to identify the systemic source of infection also, but the blood culture and urine culture were negative. So there was both eye senile cataract with left eye focal endogenous endophthalmitis and endophthalmitis with the likely etiology Candida. We went ahead with left eye posterior vitreous biopsy because the lesion was quite in the periphery. Over the retinitis lesion, we did the posterior vit biopsy and injected intravitreal antibiotic. Although a strong suspicion of Candida was there, but still we injected antibacterial along with antifungal. Now because of the strong suspicion of Candida, we started the patient on oral fluconazole 200 mg. Vitreous biopsy didn't show any organisms on smear and didn't show any growth on culture also. After 3 days, we could see that the retinitis lesion is increasing in size, vitritis has also increased, and the vision has dropped from 20 to 50 to counting finger close to face. So we shifted the patient from tablet fluconazole to tablet posaconazole. Now posaconazole has stronger affinity for the target and it is known to work for the mutant strains also, and its efflux is very slow. So when all the drugs are already eradicated, this drug is still active comparison to fluconazole and voriconazole. So we shifted the patient from fluconazole to posaconazole and we planned for a pars plana vitrectomy with repeat intravitreal antibiotic injections along with antifungals. Now despite 4 intravitreal antibiotics and antifungals, the lesion was not responding, vitritis was increasing and the lesion was status quo. So what next? We were dealing with a case of recalcitrant endogenous endophthalmitis and vitreous biopsy also didn't help us in this case. So we planned for a silicone oil injection. Now silicone oil injection has a bactericidal and a fungistatic property, so it was going to help in both the cases. So we went ahead with silicone oil injection. Now patient, because of the cost factor, since posaconazole is quite costly, we shifted the patient back to fluconazole, and patient was also started on the first cycle of chemotherapy for his adenocarcinoma of the stomach. Now after 1 week of this presentation, we could see that the lesion has quite increased in size, and as it is an oil-filled eye, there was no increase in vitritis. But the lesion, you can see on OCT also, it's a double bump can be seen. So what could be the cause for the increase in size of the retinitis? Either it could be that we shifted the patient back to fluconazole, or it could be that after the patient was started on chemotherapy, the fungus started to proliferate more. So now nothing can be done, we can't stop chemotherapy. After giving all the intravitreal antibiotics, systemic antifungals, pars plana vitrectomy and silicone oil injection, then also the lesion was not responding. So what next? We went ahead and did cryotherapy to the retinitis lesion, because this retinitis lesion was in the periphery. So double freeze thaw technique of scleral cryotherapy was done. There were 3 sittings of cryotherapy done. Firstly to the nasal margin of the lesion and to the surrounding retina, then to the temporal margin, and then to the center of the retinitis lesion. And here we can beautifully see that the retinitis lesion has completely resolved and there is no recurrence post cryotherapy. Now this is the timeline showing that retinitis lesion, which was increasing despite antifungal antibiotics, oral as well as intravitreal, pars plana vitrectomy and silicone oil injection could not help. Then cryotherapy acted as a last resort and helped us in resolution of the retinitis. So there were 3 learning points from this case. If there is a retinitis foci which is growing progressively into the vitreous, and there is a history of gastrointestinal surgery, likely causes candida for that endogenous endophthalmitis. Silicone oil injection in cases of endophthalmitis, it has a bactericidal and a fungistatic effect. So the studies have shown that the strains of bacteria responsible for infective endophthalmitis, they fail to survive in silicone oil for longer than 3 days, but fungi can still persist. This could have happened in our case. And cryotherapy can be used as an adjunct in recalcitrant endophthalmitis in absence of favorable response to conventional therapy, as happened in our case. Thank you.
Very nice documentation again.
Thank you, sir.
Fungal focal endophthalmitis actually is well documented after any gastrointestinal surgery.
Yes,
I also have multiple patients like this. The only difference I have done is that, personally speaking, on the look of it, clinical picture to me does not look like candida.
okay.
It looks more, because candida lesions are slightly whitish in color and they are slightly smaller compared to a big granuloma. This is yellowish looking lesion. Normally candida will be whitish, and whatsoever I have seen is generally in the inferior part candida lesions and slightly whitish fluffy kind of lesion.
This was fluffy to start with,
Yeah.
but that it was protruding into only the color.
I pay a lot of importance to color also. But I think cryo, you have done an excellent job. Only thing I would have done differently is that you see amphotericin repeated injections are required even in silicone filled eyes.
Yeah, we did that.
Yeah.
We did that.
Repeated injections.
So when we were doing cryotherapy, along with that also we
Yeah.
were injecting the
Well
antibiotic and
managed.
antifungal.
See, I have one patient only where ultimately we also, you see that patient of mine, he was a medical student actually, and his vision was 6/6, and but that you know, in the upper temporal part this was not going away. So ultimately we did the same, and cryo had to be done. Killing by ice, basically, we have
Yeah.
to. That's the only way out.
So this lesion was in the periphery, so we
Yeah.
could do cryo, but if it had been in the posterior pole, then cryo would not have
If
helped.
it was on the posterior pole, then only recourse would have been repeated
Yeah.
infotherapy.
Intravitreal, yeah.
Yeah, you had some. Shout. Can't. Why was cryo done?
When would you repeat, he's
When
asking.
would you repeat an amphotericin be in an oil-filled eye, and how much dose?
The dosage I don't change, because I don't change because a lot of people say that in a silicone filled eye you reduce the dose to half.
Basically because of volume.
No, basic aim is to kill that organism, and I don't think so. It is so retinotoxic that we should half the dose. I agree with you that because silicone oil is filling the entire 4 cc of the vitreous and only space is between the retina and the oil, so dosage required will be less. But even for vancomycin and the only dosage reduction I may have is when we used to use omecacin, but no longer we use omecacin regularly. But immediately you just injected just as a cocktail of drug or
Cocktail, yes, sir,
cocktail.
because vitreous biopsy was not showing any
The biopsy
organism.
may be negative.
Yes.
It was
Especially in
getting
fungal
culture,
cases.
yeah.
Yes.
That was, yeah. Any other point?
Sir, as it is microbiologically not proven case, can we do everything in one sitting? I mean, apart from injecting every sitting around 4 or 5 injections, can
Everything
we do,
means? What do you, everything means?
injections? I mean, vitrectomy, oil, and cryo in one sitting.
I
So
would have
that-
injected oil in the first go. Normally, you
Yes,
see, I am very
as in
fond of putting oil in
fungal.
most of, especially in such patients. But since I think presumably the patient had excellent vision and
Yeah, vision was good
yeah,
for the patient to
therefore-
start with.
yeah.
But after third injection, it was mounting to close phase. So
That was because of increase in vitritis. But when we injected oil and there was no vitritis, vision improved for the
But
patient.
I think there is a learning in this that in contrast to bacterial, fungi do not respond so well despite fluconazole we do not use at all. We use either voriconazole or
Posaconazole.
Yeah, or alpha-derived antibiotic.
So after COVID came, posaconazole was
Correct.
remarkably
Goes
used.
away and then comes back again.
Yes.
Yeah, yeah.
Sometimes it will just, you
Yeah.
feel as if it has gone. And then suddenly after
can
some
recur.
weeks it will start growing in.
You see, I know of another patient who was an optometrist in our hospital only, and he developed and he maintained very good vision. Ultimately, he went to seek another opinion where they did something and ultimately he lost that eye. He lost that eye from 6/6 to PL negative. So I think your management is I think well, yes. RT-PCR should have been done actually. You want to defend why did you because they depend too much on clinical judgment.
Yeah. So clinical suspicion was strong towards fungus. So even if PCR would have come out to be negative, we would have deferred change of treatment.
but I agree with you. RT-PCR should have been ordered in such patients. Should have been ordered. Nowadays,
It's a good tool.
yeah,
It's a very good
it's
tool.
a very good tool and does help in such patients.
Because in immunocompromised patient, it's not necessarily just candida, it can be some kind of a peripheral manifestation.
So any role because this patient had adenocarcinoma of
Yes.
stomach also.
Yes, yes, yes.
So because of chemotherapy, further immunosuppression.
Yeah, that could have been a factor that retinitis
Yeah.
lesion increased in
Because the
size.
lesion was not
Yeah, it
responding.
was suddenly in 1 week the retinitis lesion increased.
But a lot of take-home messages